Okay, let's continue with the third part. We were talking about FEV1, and FEV1 is definitely connected to your ability to function throughout the day, um, and also FVC. Um, we can see that patients with reduced or markedly reduced, extensively reduced FEV1 um, are more likely to die from COPD or lung cancer than others, meaning that it also has a prognostic value when you have COPD or cancer. Um, Reasons for reduced FEV1 are mainly restrictive, some kind of fibrosis, edema, space occupying lesions that we've already talked about, so I'm going to proceed. We have, of course, neuromuscular disease, obesity because of the weight that we talked about, and any deformations of the chest wall. I think FEV1 is definitely the most widely used parameter in spirometry, um, especially when you want to understand if there is an obstruction of the airway. Remember that. That's a very major and important variable to take into consideration. When you combine FEV1 with the results of FVC, it becomes, those together become a very simple screening tool that can find very robust problems, can be an indicator of the responses of the body to treatment, such as bronchodilators, um, and of course, it can be a very good indication or a way to indicate any responses during exercise-induced bronchospasm. When we're talking about the ratio between what we call forced expiratory volume ratio, FEVT percent, which is FEVT divided by FVC times 100 because it's in percent. This is a very good way to differentiate between obstruction and restriction causes that reduce FEV1. So you can see in the next slide the normal ratios that we would expect for FEV. You don't have to remember these values by heart, but we do know that people with obstructive diseases are going to have lower values than what we've seen before. I do want you to remember that a decreased FV1 to FVC ratio is the hallmark of obstructive disease. And when it's less than 75%, that is the threshold that we're talking about. When we're talking about people with restrictive diseases, we see that their FEVT percent is normal or even increased. So that makes it harder to identify using that variable, of course. When we're talking about the portion of the decrease in FEV1 and FVC, we see that usually it's proportionally decreased in both variables. When we're talking about restrictive disorders, we might see that we have a reduced FVC and a normal or increased FEV1 to FVC ratio. So that's important to notice as well. When we're talking about FEF, 25 to 75%, we know that it is measured from a segment of FEC that includes flow from the medium to small airways. When you look at the percent, you're actually deciding what portion of the airways are you testing. Does that make sense? So if you're taking the 1%, you're looking at the start of the process of airflow. If you're talking about 100%, you're looking at the end. If you're talking about 25 to 75%, you're taking, in theory, the middle half, the middle 50% of the airways. So in this case, this would be mid to small size airways. Does that make sense? So the normal values, as you can see, is 4 to 5 liters per second. And when we have the presence of a borderline value, we can understand that we may have obstruction of the airways. And of course, the percentage lets you know the location of the obstruction. Okay, so a lot of machines produce what we call a flow volume loop, an FVL, which shows how volume changes per time during exhalation and inhalation. So basically it's a graphic way of describing what's going on in the system, and you've probably seen such curves before. And you have one, an FVL, on the next slide. I don't want you to memorize the FVL. This is just an FYI. And you can see that it has different indications of the variables. Once again, I'm not going to ask about this schematic. It's just to have you know how it looks like and have you customate it with its look. You can see schematically on the next FVL what happens in different conditions. Once again, I am not going to give you a picture or a schematic and ask you what is this, what is that. But you can see that according to restrictive and obstructive conditions, the loop that you get is either located in or out of the normal range, or of course is definitely smaller, meaning a decrease in the total value. When you look at severe obstruction, you can see how low the graphs are. You can see how the loop number 2, how small it is in comparison to number 1, and that means that, and as we indicated, it's an indication of severe obstruction, and you can see that in the total value and capacity of the system. It's only natural to show what happens with dilators. So you can see that the darker part is the pre-dilator, and then the post, and the circles are the predicted. So analyzing this FVL, we see that the pre-dilator is less than the predicted, and in most points of the most parts of the flow. And then after the dilator, you exceed the predicted, and at some points you even are at the predicted. So obviously this is a change in the ability, the functional ability of that person. Continuing to peak expiratory flow, PEF, maximum flow obtained during an FVC maneuver. This is actually a measurement, so you need to have an FVL to measure it. Usually, because you are measuring from a loop, from an FVL, you want 2 or 3 good takes, and this is used mainly to understand the larger airway function. And there's lots of kinds of portable devices for that. It's used to indicate asthma. Um, Basically, once again, you're not technicians. I don't want you to be technicians, but you are going to use the best loop out of the three. Is usually measured twice a day, once in the morning and once in the evening. We know that we have changes throughout the day, temperature-wise, fatigue-wise, biological clock, and so on and so forth. So you definitely want that measured twice a day if you're trying to understand what a person is going through. And of course, it's subjective, so you're comparing it to the same person's best test lately or peak values. You can see that the National Asthma Education Program suggests a zone system with three colors: green, yellow, and red, according to a traffic light. And of course, the green means that you're 80% to 100% of personal best. You can continue with your routine treatment and even consider, in some cases, reducing medication. When you're talking about the yellow zone, you're at 50 to 80% of personal best. Acute exacerbation may be present. Temporary increase in medication may be needed. Notice that it's temporary, that it's not necessarily chronically happening. And you might need to increase your maintenance therapy. At the red level, which is less than 50%, dilators should be taken immediately. Oral steroids, we're talking about notifying your clinicians and your physicians, and we want to see you going back to yellow or green within 2 to 4 hours. This is, of course, important because someone with such a condition may come to you with results, and often they do. You can see the machine on the next slide. It's very portable, very simple to use. You have the ranges. You can have it in your backpack. It's that small, and it's an indicator of what to do next, right? So it's not the whole solution, but it's an indicator. Talking about MVV, the volume of air exhaled in a specific interval during rapid force breathing. So you are forcing a certain pace of breathing on the person. It has to be rapid, meaning recoil is very fast, and it's forced breathing, meaning beyond the normal values that we've talked about. It tests the whole overall respiratory system. It sees, the whole span of the system's ability to function. It will give you a good indication of airway resistance. It would involve respiratory muscles because we're talking about forced breathing. It will indicate the compliance of the chest wall and the lungs, and show us any problems regarding ventilatory control mechanisms. So we want VT to be about 50% of VC, and we want a person to conduct this test for about 12 to 15 seconds, and you can see that you can see normal breathing right in the middle, and then you can see the test going up. When you extrapolate to 60 seconds, you can get the normalized results to BTPS. and it's supposed to be equal to 30 times the FV1 of a person. So you can also, of course, compare the two. When is it decreased? In patients with moderate to severe obstructive lung disease. Patients that are weak or have decreased endurance are definitely going to show a decreased MVV. We have neurological deficits due to the inability to activate muscles through the nervous system. Any paralysis or nerve damage. So basically, you can see a trend here that anything that is originating from the nervous system is a major reason for decreased MVV. When we have people that have undergone or will undergo abdominal and thoracic surgery, a decrease in MVV is definitely one of the results that we can anticipate. We've talked about a bit about bronchodilators. When we want to see the influence of a bronchodilator on someone, their specific and personal responses. Obviously, we are going to have them go through spirometry before the use and after, and those are the loops that you saw before. If we can bring a person with the dilator to about 1% from their predicted FEV1, that's a very good result for a dilator. If with the dilator FEV1 is still FEV1%, is still 70% of the predicted, that will be an indicator of an obstruction in the system. When we're talking about FEV1 and specific airway conductance, which is called SGAW, they're usually evaluated and not measured. And as we said, the lung volumes should be recorded prior to the use of the dilator, otherwise you have a problem because you can't see the change in the system and you can't estimate the difference. Lung volumes and Delco can definitely respond as well to dilators, which is a good thing. So FEV1 is definitely by far the best indicator to the effect of the dilator. Contrary to FEV1, and this is an important point, once again, you're not the technicians, but you should know, FEV1% should not be a good indicator of the bronchodilation response because it's not absolute and it's in percentage, and FEV1 is absolute, so that's a better way of indicating the actual effect that the dilator has on the system. Okay, so you can see that an increase in the Saghiv due to bronchodilator therapy of about 12% and 200 milliliters is regarded as a significant difference, and the Saghiv itself will increase by 30 to 40%. When we're talking about diseases that affect the smooth muscles of the airway, we'll definitely see a significant difference and improvement from the before to after. We can see an increase of above 50% in asthma patients, which is awesome and great. But when we test or look at the values of people with chronic obstructive diseases, we see no to very little improvements in their flow. All right, MIP, maximal inspiratory pressure, is the highest pressure developed during a forceful inspiration against an occluded airway. This is very important variable because it shows us what kind of force can be produced while the system is occluded. Obviously, the higher pressure that you produce has both a negative and a positive outcome. The positive part is the flow, right? If you can produce higher pressure, you can increase the flow within the system, opposing the occlusion. Just remember that you're talking about a force. When we talk about pressure, you're also pressuring and influencing the tissues around that area of the occlusion, and that can cause irritation. It can cause, it can be a mechanical cause of injury that may lead to inflammation. So, of course, the aspects of such occlusion causes us to need higher pressures to be able to have airflow within the system, but it also takes a toll on our health at the same time in the sense of hurting tissues around us. Of course, this is a direct indication of muscle strength and respiratory muscles' ability to induce high pressure in the system. We of course want to see the highest level, meaning maximal expiration, and that's the point where we want to measure that value. So it's measured at FRC as well, and maximal exhalation. There's different ways to record it. You can see that it's recorded in either centimeters of O2 or millimeters of mercury. You don't have to remember the numbers here. Who's going to have the decreased MIP? First of all, neuromuscular diseases, of course. Anything that will affect the respiratory muscles will, affect their ability to produce power and pressure. Obviously, any disease that involves the diaphragm, the intercostal or the accessory muscles, any problem with hyperinflation, because water cannot be condensed, so you're trying to condense water, they're going to battle you and push back and resist. Of course, this could be a good I'll correct myself, a somewhat good indication to respiratory muscle training, which is a method used in general, where you train your respiratory muscles and you see the decrease in fatigue and the increase in their functional capacity. Of course, when we go to a certain radical level of things, it may be used with people that need ventilation support. When we're talking about MEP, maximal expiratory pressure, same idea, only with expiration. The focus here is on the abdominal muscles and the elastic recoil of the lungs and thorax. So the focus is a bit shifted. Of course, It is usually measured at maximal inspiration, meaning total lung capacity. Can also be measured as well at FRC. Same units used to record the results, either by centimeters of water or Hg. Once again, we'll see a decrease in neuromuscular disorders, high cervical spine fractures because of the location in the back, and since we are analyzing the function of the thorax, which is connected to the spine, it's definitely going to influence its ability. Any neural damage to the ability to control the abdominal and accessory muscles in inspiration will definitely cause a decrease here. A decreased MEP is associated with the inability to cough, so that is a hallmark sign that should lead you to think about decreased MEP. These situations might be complicated and lead to chronic bronchitis, CF, and any other condition that will produce extensive amounts of mucus. We can see in the next slide the graphs of MIP and MEP. You don't have to know how to analyze this graph. Just wanted you to see it. In this case, the units are centimeters of water. Okay, one of the major aspects of any system, as I have said again and again, is the resistance. And its names says everything. So airway resistance, called RAW, or in this case the abbreviation is resistance of airway, is analyzing or indicating the driving force or pressure, in this case, required to create a flow of air through a subject's airway. So obviously those are the three balances that we were talking about. And you can see that the units are centimeters of water per liter per second. When we are relating it to lung volume at the time of measurement, meaning you're comparing the flow or the pressure of flow needed to a certain lung capacity, you get what we call specific airway resistance, or SRAW. So that would be an indicator of what pressure is needed to produce a certain capacity. The first one is just looking at the pressure without the capacity. So obviously the SRAW, the SRAW, is an index, whereas the raw is not. You can see the values. You do not have to remember the values for the exam or at all. If you do remember, that's cool, but you don't have to. When is it elevated? Remember, we're talking about pressure. We're talking about a force. So what would elevate that force? Obviously a bronchospasm. If you have something contracting at once, the pressure that is produced is elevated. Inflammation will cause the pressure to go up because of fluids. Mucus secretion. So basically, when you talk about pressure, you're talking about a force per some kind of area, surface area. So anything that decreases the surface area is going to increase the pressure. So we see a spasm, a decrease in the diameter of the airway. Inflammation, we have fluids in the area, increases the pressure. mucus secretion increases the pressure in the area. Any air collapse, airway collapse, obviously decreases the surface, increases the pressure. Obviously, any kind of masses growing into the area or forcing the area. So those would be lesions, tumors, traumatic injuries, foreign bodies, fat, and so on and so forth. It's the same principles, and again. These will, of course, be increased in acute asthmatic episodes. It's increased in emphysema, any narrowing of the airways and collapsing. So basically, any obstructive disease will cause an increase of RAW, and the increase in RAW is proportionate to the obstruction within the airways. Then we have the last variable that we will talk about, which is the airway conductance, what we call the jaw, the GAW. This is a relative variable that looks at the flow in comparison or related to a certain drive pressure. So how does the flow react to pressure? Okay, you can see the units, and we have an inverse relationship between the GAW and the RAW. Okay, once again, we can look at the certain driven pressure and what flow it creates relatively to the volumes that are the results of that, and that, of course, is an index, and then it's called specific airway conduction, or SJAW. You can see that we can use a system, whereas we can basically calculate both the raw and the jaw. You see the normal adult values. Once again, you don't have to know the values. If you happen to do, that's awesome, but you don't have to. And that's just for comparison in the future if you ever get results from someone. When we have a decreased SJAW value of less than 0.15 to 0.2, we know that that's consistent with airway obstruction. So that's the end of the videos for week 7. Tomorrow I will upload videos for week 8 and 9.